Skip Anderson, Associate Editor of JACC Interventions, and I'm here today to interview Dr. Jorge Salcedo from the University of Oklahoma in Oklahoma City regarding a paper of his to be published in JACC Interventions entitled Characteristics and In-Hospital Outcomes of Patients with Non-ST Segment Myocardial Infarction and Chronic Kidney Disease Undergoing Percutaneous Coronary Interventions. Welcome, Jorge. Thank you for joining us. I'd like to know first, what questions did you all set out to investigate?
We know very little about patients with chronic kidney disease that present with non-STEMI and come to the cath lab and end up having an angioplasty. So basically, we wanted to characterize most of all this patient population, the CKD patient with non-STEMI that undergoes PCI. Our main hypothesis was, of course, that these patients were going to have worse clinical outcomes, and we tried to focus our research on hard endpoints such as death and bleeding complications in this group of patients.
I see. And where did you obtain your data set for examining this?
We thought that one of the best databases in the nation precisely to look into this is the Action Get With The Guidelines registry. So we were able to obtain about 40,000 patients that fulfill the inclusion criteria over a 3-year period of time that had precisely these patients that came with non-STEMI and came to the cath lab and had an angioplasty. These patients were then studied based on the renal function, and outcomes were looked at.
I see. And how did you group the patients with chronic kidney disease? You created groups.
That is correct. So of these 40,000 patients, we decided that the best way to look at renal function or calculate GFR based on the data points that we have from the Action Get With The Guidelines collection data form was to use the MDRD equation. So we group our patients based on GFR less than 30, so those would be patients stage up to stage 2 as normal renal function. And then patients who had stage CKD 3, 4, and 5, we compared against patients that had those GFRs greater than 60. So basically 4 groups.
4 groups. So the no disease and the mild disease formed one group, and then the higher level disease formed the other 3 groups.
Correct.
And the dialysis patients were considered the most severe. That was the
yeah, GFRs less than 15, including dialysis patients, were included in the CKD stage 5.
I see. And what was your primary outcome measure?
Death. So we looked at death. We did multivariate analysis. And what we found, as you could have expected, is that patients that come to the cath lab, have an angioplasty, and have renal dysfunction had higher death. And it was quite dramatic indeed. So when we looked at the patients without CKD, the mortality rate, in-hospital mortality rate, was 0.6%. If we looked at the group that had the highest mortality, the CKD stage 4, mortality rate was over 6%. So there was 10 times greater mortality in patients with CKD stage 4. And that was one of the most interesting findings of our paper that was led by one of our fellows, former fellows, Elias Hanna, that the stage 4 CKD patients actually were the ones that did worse.
I see. So how can interventionalists use this information that you're publishing?
Well, if I can add a little bit to part of the story, because although that was our primary measure, there were a couple of very important findings, which I think are probably more relevant for the interventional cardiologist. These were the patients that, of course, the physician thought that they were healthy enough, CKD patients healthy enough to go to the cath lab and have an angioplasty. Despite this, we found that many of these patients did not receive guideline recommended therapy, less use of statins, less use of antithrombin agents, beta blockers, and so forth and so on. So that was quite interesting. The second thing was the bleeding issue as well, and I would like to narrow, because that was also one of our more relevant outcome measures, and we found that there was a 3-fold that is after multivariate analysis, greater risk of bleeding complications as defined by the Action Get with the Guidelines bleeding score in the CKD stage 4 as compared to the patients without CKD or minimal CKD. So I think that more information, more data are needed to try to better characterize therapies that would improve the outcome of these patients. But these are clearly very, very high-risk patients that deserve the attention of the intervention list to try to improve those outcomes such as death or bleeding.
Right. Okay, thank you very much, Jorge. Thank you for joining us. This is Dr. Skip Anderson, Associate Editor of JACC Interventions.